thank you all for joining us for this month's ICMLF conversation. It really is a privilege to be part of this monthly conversation and having the experts talk to us about the different topics each month. So this month we are privileged to have Dr. Ekaterina Chelysheva from the National Research Center for Hematology in Moscow, who is going to be talking to us about the balance for a mother during pregnancy when you have CML. And also, we also have the topic, a balance for the baby, presented by Associate Professor Elisabetta Abruzzese from Rome in Italy. So again, my thanks to our speakers, and I will hand over to Dr. Abruzzese, who is just a brief introduction perhaps. So Dr. Abruzzese is Professor of Hematology and Director of the CML and Lymphoma Clinic at the Hospital Eugenio at Tor Vergata University of Rome in Italy. She obtained her PhD and MD degree from the University of Rome and completed postdoc studies on cancer genetics at the Bowman Gray School of Medicine in Winston-Salem in the US. So she has been actively involved as principal investigator in multiple clinical trials on CML and lymphomas, including phase 2 and phase 3 studies from the GIMEMA working group on CML. CML and pregnancy is one of Dr. Abruzzese's main research interests. She is responsible for the Italian Registry of Pregnancy and Conception in CML patients and co-responsible of the ELN Registry of Pregnancy and CML patients and co-founder of the PR Pregnancy and CML Treatment International Committee. So a true expert to talk to us today. My thanks, and I will hand over the screen.
Thank you. And my subject today is to talk about pregnancy and CML from the baby side. That has not been explored too much as the mother side, but is of course very, very important. And you all know that with the past introduction of the TKIs, the collateral effect of a really successful treatment is expanding the family, because this is the most normal thing that you think when you want to go back to a normal life. And as you can see from this slide that I shared with Ekaterina, in the past 10 years, pregnancies that ended to labor increased exponentially together with the increased knowledge about this subject. What is the background? You all know that the introduction of tyrosine kinase inhibitors has dramatically changed the prognosis of CML patients. Patient diagnosed in chronic phase can expect an excellent disease control and a normal lifespan. Median age of diagnosis in Europe and US around 55 to 60 years, while in emerging countries, this median age is 10-15 years lower. So we can expect more than 50% patients diagnosed in the reproductive age. For this reason, pregnancy are justifiable and should and can be planned as successfully accomplished. This is why issues regarding fertility and pregnancy must be introduced at diagnosis, and everybody should have a knowledge about working on this subject. For this reason, in 2013, the GIMEMA CML Working Party in Italy, and at the same time, the ELN worldwide, initiated a retrospective prospective study to describe all male conception and female pregnancy outcomes in the CML population. And this is a registry that we share together with Ekaterina, is one of our, as Nicole has said, main subject of interest for CML research. The objective of the study was to describe CML patients in terms of pregnancy, conception, management, and outcome. Those are the participating centers in Italy. The first results were presented at the ASH 2019. We had 168 pregnancies and conception, And the other registry is the international one. As you can see, is not only European, but it involves countries all over the world, and it accounts for 224 outcomes in the female patient population. So we can have approximately 500 patients for which we can present the data. The addressed question, were pregnancy related, CML related, and baby related, particularly regarding the birth, the psychomotorial development, the development of language, and the school performances. So we divided those outcomes in three group of age: 0, 3 for mainly the psychomotorial development, 3 to 6 for the language, and more than 6 years for school. What do we know about TKIs and the other drugs that can be used in CML? We know that TKIs are teratogenic and embryotoxic. What does it mean? It means that when a female patient carries a pregnancy, the TKIs can be toxic for the baby, while those drugs are not genotoxic or mutagenic in animal studies, and it seems that this is also confirmed in human subject. What does this mean? It means that the drugs cannot damage the DNA of the gonads of ovary and the spermatozoa, and this means that there should be no problem in conception, pregnancy, delivery, or increasing congenital abnormalities in men taking TKIs because they don't carry a pregnancy, while a caution should be reserved for people treated with ponatinib because it's a relatively new drug and we don't have a lot of information. While female that carries pregnancy, they must be cautious because of this problem. We know that the prevalence of congenital defects in birth registries is a little below 3%. Regarding the men's side, approximately 450 pregnancies were reported in partners of men on therapy, most on imatinib, of course. Some events were described of abnormalities, but those were commonly found in general population, and they were not related to the drug. As you can see, this paper recently published a report on 428 pregnancies from 374 fathers that conceived without treatment discontinuation. You can see that there were some problems, but the percentage of those problems was approximately 2.3%. This means that the threshold is below the one of the general population. Further, the abnormalities that were found were the one present in the general population. Different is the subject when you talk about female pregnancy. It was well described that imatinib and all the other drugs can induce fetal abnormalities, and those abnormalities are not really within normal incidence. As you can see, they are present in patients treated with TKIs in 3 out of 125, while the normal incidence is 1 over 4,000. Also, the kind of abnormalities that include problems with bone, with the brain, vascular and organ defects are more related to the same abnormalities that were found in animal studied before the in preclinical studies. However, imatinib and nilotinib, they present both little placental crossing. This means that when placenta is formed, the drug crosses poorly the placenta, and this means that after placenta is formed and organs are formed, the exposure for the baby is limited, while dasatinib crosses the placenta and can induce problems in any stage of pregnancy. Some reports were analyzed for bosutinib, ponatinib, and also radotinib, but they were small cases. What is considered a problem during prenatal development? As you can see from this slide, you start the pregnancy counting the first obstetrician week, the first day of the last menstrual cycle. This means that for 2 weeks, the ovocyte gets to maturation, it gets fecundated, and then it starts growing. After 2 more weeks, that means 4 obstetrician weeks, around 4 to 5 weeks, there's the implant of the embryo within the uterus. Is this the moment when the drug can be in touch with the baby? And this is the moment approximately after the 5th, the 6th week, when the majority of organs that can be attacked by TKIs are formed. This should be the period in which you should not expose the mother to the drug. While after placenta is formed, we have the fetal period where organs are mainly already formed, and we know that some drug cannot pass the placenta, and for this reason some of those drugs, mainly nilotinib and imatinib, can be taken into consideration in case of need for the mother. What the registry highlighted, this is the GIMEMA registry concerning the pregnancy. As you can see, we have 1/3 the cesarean section. That is approximately the same percentage that we have in normal pregnancies in Italy. And the pregnancy did not increase this percentage in female patients. The week of delivery was approximately the one that should be between 40 and 39 weeks. And as expected, breastfeeding in female patients were a little little present comparing to male patients. Those are the outcome of the babies. Those are the baby boys, and those are the baby girls. And you can see that the majority of those patients had a normal gestational time, approximately a normal weight and a normal length. Considering the development of the babies, a large portion of those babies have encompassed already the 6 years of age. We have up to 18 years baby follow-up, and we didn't find any problem at any age. Development was normal, walking and talking within normal range. All kids are alive, no malignancies, no CML, academic performance as compared to other children at school. We had some problem for some patients at birth, and also a couple of problems that were solved. The language problem was fixed after logopedy and after going to elementary school. Those are the data from ELN. The number here are higher, and as you can see also here, preterm birth were not so high as you would expect. Cesarean section were a little more. All patients studied, they had some kind of treatment when they got pregnancy, when they got pregnant, and those are the drugs that were used. Those at conception, and some took some drug after the 2nd or the 3rd trimester when the placenta was formed. 13 cases used imatinib for the whole pregnancy, and fortunately we didn't have any problem. The abnormalities using TKIs during the organogenesis reach 10 to 20%. That of course is a lot higher than a regular pregnancy. This does not mean that you have to take drug during this period, but this means that if you took accidentally a drug during this period is not sure that you're going to have problem with your baby. Characteristic of the newborns also here, small birth abnormalities, and none of the abnormalities were severe or life-threatening. Median age of children was 5 years, range 2 to 17 years at the last evaluation. And also those babies were uneventful for their problems. So we know that managing pregnancy in CML is balancing the mother, the baby, and the illness. All three are mutually important and connected between each other. It's certainly feasible for men and women childbearing age to carry, plan, and successfully accomplish conception and pregnancy, fertility, conception, and delivery for female partners of male patients with CML poses limited concern, while female patients, as we said, should not be exposed to TKI during pregnancy, being those potentially embryotoxic and teratogenic. Babies born from a CML parent do not present differences with same group population. Female patients should stop TKI at first pregnancy test positive. No treatment should be administered unless necessary until organogenesis is complete, 13 to 15 weeks. After this period and after placenta is formed, the TKI with low placental penetration can be considered, while interferon can be used at any time. And with the smile of most of our babies, I will hand the presentation to Ekaterina, which shares with me this important subject. Thank you for your attention.
Thank you so much. Thank you, Dr. Abruzzese. As Dr. Chelysheva gets ready, I'll just perhaps give a short introduction. Again, just reminding people that you can ask any questions as we go in the chat. We'll address those questions at the end of the presentation. And Dr. Chelysheva is going to be giving the next part of the webinar, which is the perspective of pregnancy from the point of view of the mother. So Dr. Ekaterina Chelysheva is a senior researcher at the Scientific and Advisory Department for the Therapy of Myeloproliferative Disorders at the National Research Center for Hematology in Moscow. CML in pregnancy has long been one of her main research focuses, and she has authored many publications on pregnancy outcomes for patients in CML, pregnancy management in CML patients, as well as evidence and recommendations for the use of tyrosine kinase inhibitors during pregnancy and breastfeeding. So as mentioned, she will share her expertise on CML and pregnancy with us today, with the focus on the mother during pregnancy. Dr. Chelysheva?
Yes, thank you very much. Good day, dear friends. Now we go to CML pregnancy, questions of balance for the mother. When we talk about CML and pregnancy, we see three mostly different situations regarding pregnancy during CML diagnosis, pregnancy on TKI treatment, or possibly a pregnancy in a treatment-free, stable, deep molecular response. The last situation is very rare, so the first two ones are met more frequently. And a balance for a mother, of course, is in a close connection with the balance of risks for a child. We have to weigh the risks of no treatment during pregnancy versus the treatment options that we have. And these options are limited. Sometimes we can feel like looking into the crystal ball to make a prediction of an outcome for the woman. As a treatment-free pregnancy is a period with the probability of a disease relapse, we have to understand what degree of response loss is safe, and the key questions is when to treat and when not to treat. In the Russian part of the pregnancy database, the final number of the collected cases to ELN registry is 205. 70% of these pregnancies ended with childbirth, with 17% of cases when CML was diagnosed during pregnancy, and most cases were represented with pregnancy diagnosed during therapy. We have the cases with a high leukemic burden at pregnancy start and on treatment with BCR-ABL more than 1%. And we have the cases with the measurable leukemic burden when you can distinguish the molecular response. It means that the levels of BCR-ABL are less than 1%, and you can see here MR2, MMR, or GMR, deep molecular response. We have analyzed the molecular response in pregnant patients with initial level of BCR-ABL less than 1% and found that MR2 during interruption in treatment during pregnancy was preserved only in those patients who initially had a deep molecular response. A median time for MR2 loss was 2.5 months after treatment interruptions. Moreover, we found that only patients with initial deep molecular response and TKI therapy for more than 3 years could keep the MR2 during treatment interruptions, while all other patients lost the MR2 during treatment interruptions. However, when the TKI therapy was restarted, all 3 subgroups of patients restored their response, and it was significantly faster in those patients with initial deep molecular response compared to those having no initial DMR and having only MMR or MR2. So the leukemic clone is sensitive to TKI restart in patients with initial level of BCR-ABL less than 1%. There was a discussion of the interferon role during TKI interruptions for pregnancy in the recent article from the authors from Australia, and a very careful presentation of BCR-ABL molecular kinetics was shown for the cases with the interferon use. Here we can see that there was no growth of BCR-ABL in some cases after interferon administration, and while in some cases there was a significant growth of BCR-ABL, even in spite of interferon was used. Besides that, there were the cases without interferon use, treatment-free pregnancies, and here we could see the same picture of stable level of BCR-ABL or rapid increase of BCR-ABL, but again, very good information is that after TKI was restarted in all those cases, the response started to improve. And there is the statement which I like very much, and it is supported by the practical experience, that disease sensitivity to TKI therapy may be practically the most relevant determinant of safe TKI interruption for pregnancy. So the responses can be regained again. We also analyzed the survival without MR2 loss in different subgroups of patients with and without interferon, and we found no significant differences in the cohorts of patients with MR2, MMR, and GMR. However, surprisingly, in patients without MR2 with the initial high level of BCR-ABL, it was a good treatment option to preserve a complete hematologic response. It was maintained in 6 of 7 patients, and use of interferon in 1 patient with T3 mutation T315I could maintain a complete hematologic response before ponatinib was available after the delivery. So use of interferon had no impact on MR2 preservation. However, it helped to maintain a complete hematologic response. The subgroup of patients with the initial high tumor burden and BCR-ABL level more than 1% on treatment was the most problematic group. Almost half of these cases were the non-compliant patients who interrupted treatment before pregnancy. In half of the cases, the absence or loss of molecular, of not only molecular response, but absence of hematologic remissions was noted. And unfortunately, 3 patients died after delivery due to the progression of CML. The probability of MMR achieving after treatment restart was very low, and it was absent in patients with initial absence of hematologic remission. So non-compliance or absence of hematologic response were extremely unfavorable factors. Another story is the high leukemic burden at the beginning of CML when disease is diagnosed during pregnancy. The patients are untreated and the disease is sensitive to TKI treatment and to other treatment. You can see that CML can be diagnosed in any pregnancy trimester, and treatment start gives a good chance to obtain a complete hematologic remissions before delivery and to treat these patients as normal patients, which is very important to have a complete hematologic remissions at delivery. When these patients were treated after delivery, we could see that cumulative frequency of MMR at 12 months was relatively low. But after switch to more potent TKIs, it was possible to achieve good rates of MMR within 2-3 years of therapy. So the scheme of CML management during pregnancy was developed in our center, and we have several statements in it. First is that planning a pregnancy is optimal for patients with more than 3 years of deep molecular response, with more than 3 years of treatment and more than 2 years of deep molecular response. This is the safest situation for a mother. TKIs should be stopped immediately after pregnancy confirmation, and no therapy is advised until 12-15 weeks, until the placenta is formed. And after this time, after 15 weeks of pregnancy, if we have a patient with a high leukemic burden or absence of hematologic response, we can think about using individual TKIs, imatinib or nilotinib, because these drugs have a limited transfer across the placenta. We can also use interferon at any pregnancy stage when it is not possible to use TKI, as well as we can use it by physician or patient preference to preserve a complete hematologic response. And really, the average number of births for the last 8 to 10 years increased greatly, and now we consult about 13 cases which end in childbirths every year. We have accumulated this data and made a review of the actual publications and gave our provisional suggestions on behalf of the authors from so-called practice group. And here we again consider the initial BCR-ABL level at pregnancy confirmation. We consider the BCR-ABL level at 15th week to form our decision about how to treat this woman in the second and third trimester, whether to use treatment or not to use. So what information, in summary, do we need to make a prediction for a woman? Information about dates of treatment and treatment interruption, information about molecular monitoring before pregnancy, from what starting point we come to monitor her during pregnancy. Then follow-up during pregnancy, including initial molecular response at 15th week, and BCR-ABL can be evaluated every 6-8 weeks or more frequent if we observe a rapid rise or have some other consideration. We advise to evaluate BCR-ABL close to delivery date to think about breastfeeding or not, and complete blood count every 6-8 weeks or more frequent if needed. When a patient is returned to therapy, to TKI, We treat her as per clinical guidelines, but very carefully be sure that at least initial response had been restored, that the woman is compliant, and that the response can be improved furthermore. So, in summary, the knowledge of CML management during pregnancy allows to realize childbearing function in patients with different tumor burden. The sensitivity of leukemic cells to TKIs is a key issue of a controlled treatment interruptions. A sustained deep molecular response is the optimal condition. MMR and MR2 in some cases can be acceptable with the strict molecular monitoring, but the absence of MR2 during treatment is or absence of complete hematologic response during treatment are dangerous conditions for planning pregnancy. The use of interferon allows to maintain a complete hematologic response, and this option can also be considered, but we should know that there were no significant difference for preservation on MR2. So here I would like to stop and finish the demonstration.
Thank you very much. Thank you, Dr. Chelysheva. I really appreciate a very comprehensive overview. I'm sure there's sort of lots of questions bubbling away. Again, for people who've joined us, please write your questions in the chat and we'll pick up as many as we can. Perhaps leading on from that excellent summary, I'll just ask that question from Professor Saglio to Dr. Chelysheva. Is there any role for hydroxyurea?
In fact, hydroxyurea, as we all know, is known with a proven teratogenicity, and it is considered non-safe treatment option during pregnancy. So we try to avoid hydroxyurea but if we have no other choice and have to fight the hyperleukocytosis, for example, in newly diagnosed CML, we used it just for several days to skip the leukocytosis just for 3-5 days in a dose on not exceeding 2 grams, for example. So it was a very short period in very individual patients. Generally, we do not recommend hydroxyurea.
Okay, and I guess sort of leading on from that, a question, any experience with PEG interferon rather than interferon?
I think that Elisabetta will answer this. We have, in fact, in our country, less access to pegylated interferon. We usually used regular interferon.
Yes, we had a shortage of production of interferon, and now they restarted. They had an agreement, but most of the preparation that we can find now is pegylated interferon. In France, they use pegylated interferon since a while, and we had 13 or 14 pregnancies that were carried on pegylated interferon, and there's no difference with the other drugs. At first, the problem was supposed to be the polyethylene alcohol that was contained in the pegylated formulation that could be toxic for the fetus for the alcohol part, but the alcohol part is so small that probably doesn't have any impact on the development of the baby.
Okay, thank you. Perhaps I can go to Professor Hughes' question then, Elisabetta. So in which patients do you restart imatinib or nilotinib in the second or third trimester?
That's a good question, and actually there's no right answer. At first, we tried not to use any kind of drug during the whole pregnancy unless the hematological response was lost. Now that we got more information concerning that, we try to use back the drug when interferon is not available, when the PCR starts to move above 1%, trying to maintain at least a cytogenetic remission. At the beginning, we didn't use any drug. Now we use a little more the drug. Of course, imatinib or nilotinib can be used in those patients that discover CML during pregnancy and have a high number of white blood cells that cannot be quickly controlled by interferon, or that they cannot be controlled by interferon. Knowing that after the placenta is formed, these drugs seem to be rather safe for the baby. Something that Ekaterina noticed is that baby that were treated with TKIs in the last pregnancy period tend to have a lower weight at birth. They are a little small for date, but not in the pathological point of view, just a lower weight compared to the week of gestation. But this doesn't have any impact on the future development and also recovery of the weight. So there's no answer. It depends from the patient, from the feeling of the patient, from the confidence of the doctor, and from the team that you have, and the possibility that you can manage this pregnancy is subjective.
Thank you. We have many physicians on the call today who are from resource poor settings, and so who have limited resources in the TKIs and treatment they can access. So questions come in. Perhaps I'll ask this to you, Dr. Chelysheva, first. How do you plan a pregnancy for a young woman with CML, stable on imatinib for the past 2 years, but in the absence of interferon and most probably without access to regular monitoring?
I think it's somewhat difficult situation if she has no access to regular molecular monitoring. I think it is a must to see, to control the BCR-ABL levels, to know where is the woman, at what condition, and what options we should give to her. So I insist that BCR-ABL levels should be controlled during pregnancy. It is very dangerous to have such uncontrolled cases, and to our experience, several uncontrolled cases were represented when we saw later the high leukemic burden, and it is really dangerous. So if a woman is planning a pregnancy, she has to have an access to the instruments to evaluate the leukemic burden, to molecular monitoring.
May I add some to this regard?
Absolutely.
Yeah. I know that the ideal situation is the one when we can control also every 3 weeks the BCR-ABL transcript. But the question Dr. Eunice posed is, how do you plan a pregnancy for a young woman with stable response on imatinib in the past 2 years? So, of course, this is a little more comfortable situation. You don't have interferon, you can stop treatment, you can control CBC. And when CBC starts to increase, and you think that response can be lost, you can restart imatinib if you have bypassed the 12th, 16th week of pregnancy. And we need to remember that sometimes those women, especially in the limited resources countries, they don't have a choice, or they want to pursue the pregnancy. So we need to put all our resources, and remember also that CML is usually not some illness that will evolve in 9 months. If it was stable for 2 years, I may consider checking on the CBC if I don't have other resources. Different is the the problem if the patient has an uncontrolled disease and gets pregnant or wants to get pregnant. So in this case, you have to arrange yourself considering the willing of the patient and also the resources you have. Of course, you have to highlight that there is a risk if the illness is not controlled, and there's a risk also if it is controlled that she can lose the response within the 9 months. But we can try to manage if at our best. I think you agree, Ekaterina, right?
Yeah.
Thank you both. I guess sort of looking at question from Giora. A patient found out last week she's pregnant while on dasatinib. She's 2 weeks into the pregnancy. Is there a danger of the time that she took the TKI? Elisabetta, perhaps I can address that one to you.
Yeah, dasatinib is a dangerous drug, but mostly during organogenesis. If she's 2 weeks pregnant, it means that she's 4 weeks pregnant, and she can stop the TKI when she discovers getting pregnant. So she should not have any problem, but she cannot restart dasatinib if needed after the 16th week. Dasatinib should not be restarted at any time during pregnancy. But if it is stopped within the first 5 weeks of obstetric weeks, there should not be a problem.
Thank you. There's also questions sort of leading on from that, sort of more about the imatinib and nilotinib. So when you're considering restarting that, at what dosage should they be restarted? Would you reduce the dose of nilotinib, or would you restart at the dose that they were on?
As for our experience, we usually restarted imatinib 400 and nilotinib 400 in reduced dose as well. So we used imatinib in a standard dose and nilotinib in a reduced dose. And there were some evaluations of the concentration of the drug in placenta and in umbilical blood, and we found that imatinib, more than 90% of the drug is stopped by placenta, and very little concentration goes to a child.
Thank you. Another question that's come in, just I think, Dr. Abruzzese, I think you did mention this, but could you just confirm what is the current thinking about male fertility when taking the second generation TKIs? There
are information concerning nilotinib, bosutinib, little on ponatinib, and some information also on dasatinib. For the mechanism of action, there's no toxicity to spermatozoa, and also for male, it works or not. If the spermatozoa is damaged, it doesn't go into fecundation and development. So theoretically, and from what we know so far, approximately 500 conception, there's no problem in male fathering children during the TKI. But of course, we cannot be sure 100%.
Thank you. I guess so. We've really come to the end of our time. So there is a specific patient question come through, and we will try and address that with the speakers offline and post that online in the clinical case discussion forum, which is on the ICMLF website. If those of you who have joined us are not familiar with that, if you go onto the ICMLF website, which is cml-foundation.org, you can find a clinical case discussion. So it's for physicians who have challenging cases. We have a speaker moderating panel who will then get back to you, and the cases will be posted live for the audience to see. So it just remains for me to say thank you very much for our two speakers today. So a really, obviously a very a widely needed presentation. Our audience was large today. So thank you to those of you who attended. And again, my thanks to our speakers today.